afternoon. I'm Meredith Wallace. I'm the program coordinator for children and youth with special healthcare needs. We're very, very excited to get to present here today. Unfortunately, when people see the DHEC logo, they just think of WIC and all the different health department things that we offer. But our little program is very specialized, and unfortunately, it's kind of obscure, and we're trying to make it a little bit less obscure. So to start off with, I just have a few little tidbits of information. In the United States, an estimated 13.8 million children, or approximately 19% of US children under the age of 18, have special health care needs. The Maternal and Child Health Bureau defines children and youth with special health care needs as children who have or are at increased risk for a chronic physical, developmental, behavioral, or emotional condition, who also require health and related service of a type or amount beyond that required by children generally. So this falls right into, sorry, I'm a little technically challenged. There it goes. Our mission statement, which is to provide support to assure optimal functioning of children and youth with special health care needs in their home, schools, and communities. So who is children and youth with special health care needs? We're basically a program with a lot of smaller programs that fall underneath that acronym. We serve approximately 1,000 clients within the upstate, but that's not all inclusive because some of our services are not captured in that number. We are a federally funded block grant program under Title V, and we serve children and youth from ages 0 to 26, but that varies depending on the program. Look, there is lifetime assistance for certain programs. We provide care coordination for each program, funding assistance, transition services, nursing, nutrition, and social work. And we will go into each one of those more in depth. So I'm going to let Shannon come up and give a little bit more information about our regions and the services we provide.
All right, so as you can see, just this is really just for your information, but DHEC is divided into 4 different regions. We cover the upstate, but each individual region has a children and youth with special health care needs program. And so our team actually includes a total of 9 personnel. So again, Meredith is our program coordinator, but we also have 4 registered nurses who act as care coordinators for our program. Myself as a social worker, and then we have a registered dietitian and 2 admin staff. And we do provide services for all 11 counties within the upstate region, but we are housed in Greenville. So there are actually 6 different programs that we have within our division. Of course, the first, which a lot of people are more familiar with, is what we were used to be known as CRS, so Children to Rehabilitative Services. But we also offer hemophilia premium assistance, sickle cell services. We do have a hearing program, special formula, and of course our most famous Camp Burnt Gin. And so the criteria for our program is that the child has to be a U.S. citizen and a South Carolina resident. So again, that's the child. I'll just leave it at that. And then financially, we do have a financial component of our program. The graphic that you see on the screen is the most recent federal poverty guidelines that came out just this week. So if you're watching online, you actually are seeing 2022 because these just came. But we really are looking at families who qualify anywhere up to 250% of the federal poverty guideline. And the big difference, that 208% number, is for Medicaid coverage. So if they fall under that 208% federal poverty guideline or under, they can qualify for Medicaid health care potentially, But we serve that gap between the 208 and 250%. So if families make even more, we can still help assist them and their children. And ours is net income, not gross. So that is their take-home pay, not their annual salary. And then, of course, if they're under 18, they have to be under 18 to apply, just because some of our programs do end at 18. And then some young adults can receive services up to age of 21, some up to 26. And then our hemophilia and sickle cell programs don't have any age limit whatsoever. And then our annual updates are required because we do have to get that financial component each year. One, to make sure if they can qualify for Medicaid, we definitely require that families do apply. If Medicaid denies them, then they have to bring that denial with to their application appointment so that we can then look at other financials. And then our next slide. Care coordination and financial assistance. So we provide these things for all of our programs. Of course, care coordination is just that. We're working with the families and the patients to provide assistance to purchase those needed services and supplies. We'll develop a payer plan, I apologize, with those families. We also make referrals out to other agencies and organizations. We will link families to family support, so like Family Connection. And then we also provide anticipatory guidance. So understanding what is expected regarding growth and development for their child and their special need, but also the benefits of healthy practices, when to expect, okay, we need to look at a dentist. Okay, now we need to go see an orthodontist. And so we provide that as well. And then we also do transition planning. And that really is more about transition to adult healthcare. We want to make sure that there's a big push now that we are prepping families and children for that big transition at the age of 18. And so we now start that conversation, and by we, in upstate, that's me. We start that conversation when the child turns 12. And families think that that's really early, but it's not. I have 3 teenagers, and I'm telling you that age between 12 and 18 goes so quickly. So we have that initial conversation at the age of 12, just so families can start thinking about, oh, these are things I need to look into. These are things I need to kind of keep in the back of my mind. And then we talk again at age 14. So then we really are focused more on the patient themselves. And we want to make sure that the family and the patient are communicating about what healthcare transition is. What is that going to look like? What questions do I need to start asking my doctor? Such as, when do I need to stop seeing the pediatrician and transition to a family practice? And then we again talk at 17 to make sure that they have that last year to prepare for what's to come at 18. So many things are going to change when they become that adult, and we want to give that family as much time and resources as possible to prepare for that. And then as far as financial assistance, like Meredith said, we do have state and federal funds to pay for services. Coverage can be limited to the level that we have the available funding. It also can be limited based on per person, per item, or per event. There are caps on certain amounts of services at times, and so that can come about. And really that's a decision made at the central office level. And then of course, DHEC is the payer of last resort. So we do require that things are billed through Medicaid and or private insurance before we can actually pay for those services. So some examples of covered items and services that we provide throughout our 6 programs, and this is not an exhaustive list, But again, just office visits, we provide coverage for some diagnostic testing. We do durable medical equipment, which now we also provide the CGM supplies for patients with diabetes. And before we did not do that. So that's a huge win for us. And then we also can help provide funding for prescription medications up to a 90-day supply. We do also provide outpatient surgical procedures and co-payments with that. And then in regards to our inpatient hospitalizations and dental services, that is related to our patients with craniofacial conditions. We also can cover corrective lenses for qualifying degenerative eye disease, and then your physical therapy, occupational therapy, and speech therapy co-insurance payments. So again, not an exhaustive list, but that's a pretty good variety of what we provide. And now Sonya is going to come present on the next few programs specifically.
Showing how to do the next slide on there. Oh, okay, I'm good. It's got instructions. I'm technically challenged. So I'm going to talk a little bit about the children's rehabilitative services. And again, this goes to the difference between having Medicaid coverage and having the CRS coverage. So we're that filling in that gap for parents that they make too much money to afford a lot of co-pays and deductibles, but they still make too much money to qualify for Medicaid, and that's where we come in. So we cover a really, really wide variety. Seizure disorders, non-febrile. If it's fever-related seizure disorder, we usually do not cover that. Cystic fibrosis, IBS, Crohn's disease. So a lot of your gastro conditions are allergy or food related. We do not cover those. But if it's not an allergy or food condition, we cover those gastro. Endocrine is probably one of the biggest CRS programs. That's the juvenile diabetes, type 1 diabetes program. We're actually embedded at Prisma. We have an office that is over at Patewood. We see patients when they come in to see their endocrinologist. We help to cover co-pays and deductibles for their insulin. As Shannon said, everybody sees the Dexcom commercials. We now can cover supplies for Dexcom, Omnipod. We cover the co-pays and deductibles for that. And sometimes if you don't have really great insurance, those can be really, really costly. We also do kidney, urinary disorders, congenital malformations, and chromosomal abnormalities like short stature, growth hormone conditions for children are some of the things that we cover with CRS. The craniofacial, cleft lip, cleft palate, we actually partner with Prisma. We do a craniofacial clinic once a month where we see patients. Patients see orthodontists, they see an oral surgeon. There's all of these doctors and they come in, and so these parents are able to come in and see all of these providers at one time instead of having, well, Tuesday we've got to go over and see this doctor, and next Thursday we've got to go see this doctor. They're all right there for that one day. So that is a huge, huge thing. And of those patients, they can have Medicaid or they can have CRS. That's one of the kind of little different programs there. Orthodontia is only covered for craniofacial malformations. Medicaid has a separate orthodontia program for kids that have something that is not a craniofacial abnormality, but at the CRS program, we only deal with children that have those abnormalities. And we also, the CRS program goes up to 18 years old, the way it's funded. We don't go further. So our hemophilia premium assistance program, I don't know if anyone knows about hemophilia. The products to treat it, factoring products are very, very expensive. Any kind of blood related supplies, we can arrange for home delivery for those prescribed blood products. Can provide premium copay assistance, for people who have health insurance. Of course, they can be on the CRS program for this. There are no age restrictions on this, but currently we don't do care coordination in the regions for this. Everything for hemophilia is handled out of our central office in Columbia. So those items are covered through that program. And they also have to have Medicaid with a contracted Medicaid provider. And basically what that means is whenever, I mean, it's just like, I know you've gone to the doctor before and they're saying, oh, we don't accept your insurance here. It's the same way with Medicaid. There are different Medicaid providers there. So it has to be a Medicaid provider that's contracted with the state in order for us to help with that. The next thing I want to talk about is our sickle cell services. This is the one that's close to my heart. Individuals that are diagnosed with sickle cell disease can receive medical services, supplies, equipment, and prescriptions. We also offer care coordination. That's what I do. I'm a care coordinator. So children who have Medicaid, most everything is covered with their Medicaid, but there's some co-pays and all that every now and then are not covered. But we offer the care coordination for those children that have sickle cell disease that are on Medicaid. We also provide premium and co-pay assistance for adults 18 or older. It's an adult sickle cell program. This coverage can last up to 3 years and then they cycle off. It's a little bit complicated, but there's a company called SCDHEC and DHEC. Together, they provide marketplace insurance, but there's a limited number of spots for that program. Currently, we have one upstate client that's on the program. I don't know the exact number of spots. I know last year we had 2 patients that were on the program. So it varies from year to year. As one person rotates off, we can put another person into that available slot. So it's kind of fluid. It's kind of ever changing. The sickle cell program for adults has 2 allotment programs. It covers medications, labs, and office visits. So those 2 different programs, if a patient has insurance, they're eligible to receive an allotment of $1,500 a year for those office visits, meds, and labs. And if they don't have insurance, then they're eligible for $2,500 a year in allotment funds. This big stipulation on that, got to call me and let me know. I have to do a special request for the funding, and I got to know in advance. You can't come up 2 days after the appointment about, oh, by the way, I went to the doctor. Sickle cell tracking and surveillance is based on newborn screenings, and that has, there's been some changes in that program, and Meredith is going to talk to you more about that after she talks to you about a couple of our other programs. Thank you for your time.
So there's a lot of, you can see, there's a lot of programs and a lot of intricacies that are very detailed. Almost everything within our program is diagnosis based. And we do have a diagnosis list. So if anybody ever needed more information, we could refer you to that list, or we could look at the list for you. But it's a lot to go over in a short amount of time, but we're doing our best. Okay, so one of our largest programs is our hearing program. That's probably over 600 of our 1,000 client caseload in the upstate. Most are Medicaid. These children can be on Medicaid, but Medicaid doesn't cover the cost. of the hearing aid devices themselves. So, we're able to help those families with those costs. We do also, though, have some families that are funded by CRS, which there again is those families that just are a little bit maybe over income for Medicaid, but fall within our program guidelines, because as she discussed, when you're talking about a net income versus a gross income, which gross income is what Medicaid goes by, somebody, especially somebody self-employed, their gross income and net income can look very, very, very differently. You may have $100,000 in gross income, but once you take all those deductions or expenses or whatever, that can drop you down to half of that amount of money. So by us going by net income makes a lot bigger difference than some people may realize. So anyways, as far as the hearing program, we do the hearing aids, cochlear implants, bone anchored hearing aids as well. Our cochlear and Baja clients actually are required, they have to be on Medicaid for us to fund it. I believe probably mostly because a lot of private insurances will cover that cost if you're on private insurance. We also cover hearing aid related supplies, including the batteries, any kind of repairs that fall outside of the warranty for those. And as you know, children, as they grow, so do their ears and everything about them. So they are constantly going back for new tubing, new ear molds and all of these things as they grow. So it's a large expense that we're able to cover for these families. Those services may continue up to 21 with Medicaid coverage. If we have families that are on Medicaid waiver programs, however, we can continue to cover that, but that all goes to central office at that point because it goes to their caseworker who actually handles that in conjunction with our central office to continue those coverages. Okay, then we also have a special formula program. This provides specialty formulas for infants and children with nutritional conditions affecting normal growth and development. These are children that have moved off of WIC and have to have qualifying diagnosis to actually qualify for that program. And the eligibility is actually determined by either a registered dietitian in our central office or an MD. They are prescription formulas. They have to be prescribed by a physician. We do a nutritional assessment with these children at least every 6 months to determine whether or not they're getting the amount of calories and so forth that they need for their growth and development. We dispense up to about 3 months a supply at a time. And if you look at, just for example, we have one family who has 2 children with cerebral palsy, and they're almost solely dependent on enteral feedings. And she picks up 60 cases of formula every 3 months that we're able to cover for those children. And that is a lot of money. That's about $17,000 of formula. So it's very vital to some of the families that we serve. We also have what is a metabolic formula program, which is for children who are with inborn errors of metabolism. Predominantly, that is like people with PKU, but I am no dietitian, so these polysaccharide multi-chain, whatever's, there are some of those as well that fall under that metabolic category. But those are very specialized formulas for those children just because of all their metabolism issues. And they're not ones that you can just walk out to Sam's or Walmart and pick up. They're very specialized. So this is a literal lifeline to some of these families to be able to provide those specific formulas for those children. And they're very highly watched by our Greenwood Genetics Center and an RD out of there named Holly Crozier. And she sends us predominantly all of our referrals for those children, and she tracks those children continuously to make sure that they're getting what they need. Okay, one other service that we provide I'm sure you're all familiar with newborn screenings that are done when a child is born. What you may not know is that there are certain diagnoses on newborn screenings that actually get referred to our program to do follow-up. There's some of these are very kind of obscure, but for these children who are diagnosed at birth with these disorders, they early intervention is crucial to their outcomes. So they've determined that this is very important service to follow up to make sure that these families are getting to the specialists that they need. Do they need any assistance in coordinating that? You know, do they need transportation services? I mean, you know, when a child's diagnosed with one of these, there's a lot of information coming at them really fast, and just to kind of be there to support them if they desire our help. So we have Pompe disease, spinal muscular atrophy was actually added last year as another newborn screening that we follow, and MPS 1. We also get referrals for first sound referrals for children who fail their newborn hearing screens and don't go for follow-up. Those are all sent to us, and Shannon, our social worker, contacts these families and makes sure that they're getting in for an appointment to be rescreened, to get to any other audiology appointments or so forth that they need to be going to. If the children has failed in both ears and we cannot make contact with them, she literally has to drive to these homes and do a home visit in an attempt to try to get to these families as early as possible. This is, everybody knows that language speaking in those first parts of life for these children is very vital. And then our fabulous Camp Burnt Gin that we put on every year down in Sumter, South Carolina. For the last few years, it's had to go virtual because of COVID. They really had pretty good participation for it being virtual, and we got to kind of lock in on some of their virtual activities that they did. They did cooking classes and art classes, and they sang karaoke, and they just had such a blast. And it was great that they were able to continue that through COVID when they couldn't do the camp in person. But this is a summer residential camp, if you're not familiar, for children and youth and adults with a wide array of chronic and physical disabilities. Our nurses from each region and we are going back in person this year, so that's great. And they got some funding for some upgrades physically to the camp that they're excited about. And but we, as nurses, I say, get to go down and help do the initial assessments on these children before they're checked into camp each year. And it is such an amazing experience because these children, they're with all the things that they have going on in their lives with their medical appointments and disabilities and things like that, their lives are just so overcome with that. And when they show up at this camp, because it's for a week, and these kids have been hovered over by their parents for so long, it's so funny to watch them when you check them in. And as soon as they get done, because we have to do a physical assessment on them and everything, just to check for bruises, cuts, anything. And as soon as we are done, they will go to that door and they're like, bye. I mean, they're like getting rid of their parents as quick as they can. I mean, they just don't want it. They're like, this is their time to be themselves and who they are. And they have one-on-one counselors with each and every child, so no child is ever left alone. It is absolutely amazing what they do down there. And like I said, it'll be fabulous to get to go down there and do that again, because I've missed going down there and seeing those kids every summer. But they have so many activities. They get to swim, they get to paint, they get to draw, things that, swimming, for instance, is a huge deal for some of these kids that are wheelchair bound or whatever. And just to see them have those other kids to relate to, and they all get to know each other, and every year they come back and they're just so excited to see their friends again. And it's just great to see them forget about, all of their health problems and health issues, which of course we have to keep up with while they're there, but they get to be independent a little bit and away from their families and away from all the stuff that they deal with from day to day. So that's pretty much the gist. I feel like that's a lot of information in a very short amount of time. I would be happy to answer any questions that you have. We do have a referral process that we can certainly email to anyone if they want to send in a formal referral. It does not have to be a formal referral. If you want to, call us, email us. I think the flyers have some of our email information. And just say we have a family that we are just interested to see if this is something that may be a service for them that they may qualify for. We are more than happy to take, as long as, you have consent from the parents that we contact them, we are more than willing to do the legwork to figure out, contact them, find out their income, what their diagnosis is, and see if they qualify. I mean, we're more than happy to do that, because we feel like that there are probably a lot of families in the upstate that we are not capturing. I mean, we can't be in every doctor's office. We're a small group, as she said, of 9 people, and we can't be everywhere at once. So that's why we're starting this newer push to try to get out into the community, to let people know that these services are out there, because the more people we touch and talk to, the more fingers that kind of get out there to reach more people. So we're actually fortunate in this region that we have a nurse embedded in Patewood, because in the other regions, they don't even have that. So I don't know how they would be capturing newly diagnosed diabetic children that would necessarily qualify for this program, because that's purely like an income-based situation. You don't look at a family and say, well, you have private insurance, so you're probably financially okay. I mean, it's something you really have to kind of sit down with a family and see where their income falls to see. So we are very fortunate to have Karen Kaiser, our nurse over at Patewood, that's kind of in the trenches trying to find these families. So anyways, does anybody have any questions for us? Yes.
How long does the referral and intake process usually take?
Oh, we're a small enough group that we get to those we are required by policy to reach out to a family within 2 days.
Okay.
So we are very quick to get a hold of any family to get that ball rolling. Yes, because if you think about it, we get a referral for a kid for hearing aids. I mean, you don't want to hold that up. That's kind of important. So yeah. Yes.
What is the age limit on the special formula?
Special formula follows, well, metabolic has no age limit. But special formula follows kind of the Medicaid guidelines. Then they're, so, and I'm not make sure, do I have that in the paper over there?
That one.
This one. Under 18, yes. We have a dietitian, as she said, in our program that actually runs both the metabolic and special formula, and she knows all the ins and outs. She knows all these different diagnoses. She's very, very well educated on all of this stuff. But yes, they can qualify as CRS too if they are a little over income for Medicaid, but they still fall within our guidelines. We have grown people coming for metabolic all the time. They come and pick up their own PKU formulas and this and that, and that just, we never stop covering that.
So if they're 19, what are their options? Because they age out at 18.
Well, I guess it would depend on what their diagnosis is and what kind of coverage they could get beyond being on Medicaid. I don't know that I can, do you know any more about what beyond Medicaid they would be able to receive assistance for formula?
I have to research them.
Yeah, I mean,
I'm sure that our registered dietitian can tell you that
Yeah.
information. And we can, if you'll do the next slide, you can put our contact information up there. But she would be able to give you all of that information as far as like where to go outside of the age of 18.
Mhm.
How closely do y'all work with DSM? Who's the administration of DSM? Are there any what you guys do?
We would love to.
Not really. I mean, some of our clients do have EDS and caseworkers.
Yes. Well, and that is one of my big things is making sure that children who potentially could qualify for DDSN services, I am constantly telling families about, have you contacted them? Do they have a case manager? Because I know there's a huge gap with that. They go to school at kindergarten and all of a sudden, and I don't know where the miscommunication is, but families just think, oh, the school's gonna take care of X, Y, and Z. And I'm like, well, yeah, the school can take care of X, Y, and Z for a little bit, but you could also get additional services, waiver-based services, et cetera. And so I'm constantly pushing that and encouraging families.
It's
out.
amazing sometimes the families we come across that their kid will be what, 10 years old or whatever, and they're like, well, I never knew that existed. And you're like, oh my gosh, you could have been getting all
Same
of
thing
this.
with social security income. I mean, I'm constantly making referrals. Well, not necessarily making referrals, but I'm constantly giving information to families to pursue. Because I know there's gaps and they could get more than what they know. It's kind of the same thing with Medicaid. I mean, if we go back and we look at those federal poverty guidelines, so many families who have private health insurance based on the new guidelines could still potentially
Yeah.
qualify for Medicaid for their children. And so you could have, you know, private insurance as your primary and then Medicaid as your secondary, and they don't know that. So those new guidelines came out, like I said, just this week. And I'm like, I'm taking a whole list of them to our craniofacial clinic on next week, because I'm like, this is very important. You could potentially qualify for additional services.
And with that, some of the Medicaid programs, because of COVID, you know, that a lot of that stuff was extended or allowed to continue. Well, that's all getting ready to end. So hopefully with this increase on the poverty guidelines, not as quite as many people will, you know, fall off that really need that service, because you know, that was really huge for this to come out early, I think, this year. And I don't know, maybe that was why they did it, knowing that some of these services were going to be coming to an end that were extended. But we were really excited to see that increase.
The other thing, there's a program called HIP, HIPP. So kids that have Medicaid, but their families have private insurance, there's a program out there where they look at what that family's insurance premiums cost versus what their private insurance covers. And sometimes HIP will actually pay their private insurance premiums so that Medicaid will be the secondary, but for that family to be able to keep that private coverage. So they pay those private coverage premiums as well as the child having Medicaid. And it's a way that everybody wins.
Right, they
Federal money
yeah,
and
they
versus
save
your
money in the long run by just covering the premium versus, you know, not covering and trying to cover individual things. So
And people would never know to look for that. And that's what a care coordinator's job is. That's the kind of things that we look at to let parents know, hey, you need to look at this program, or you need to apply for this.
HIP,
No, HIP.
HIP.
There's something, CHIP is different than HIP.
Yes.
HIPP is the health insurance premium, whatever, but it's through DHHS and Medicaid as well. Yes, sir.
I just got into this industry about 6 months ago, and I learned that I had to have a master's degree in acronyms. Anyhow, I work for Oasis of Hope, for a foster care agency, and but we recently opened up a clinic to do assessments and also therapy for speech, physical therapy, and occupational therapy. Would it make sense for, I don't know the clinical side at all, would it make sense for them to connect with you? Or
Always.
yeah,
we do it for all kids. We start off for all kids in foster care. Now we do it for all kids in Medicaid.
Oh, yeah.
So
And
this-
those kids fall through the cracks.
Yes, they do. That's why we do assessments right away. We have no wait.
and you know, there again, diagnosis based, we want to see what, you know, why are they getting speech therapy, physical
Okay.
therapy, you know, what is that underlying issue going on? And there again, we would be more than willing to take the referral and do that digging and legwork. I mean, we'd love any supportive documentation, of course, of, they're receiving things, what are any diagnoses they have? What is the reasoning or diagnosis behind the reason for them needing speech therapy, hearing therapy? Anything that you have from physicians' visits or your assessments or whatever would get us further along in the process, but.
Okay, I'll get with you afterwards and.
Okay.
Yes, you would also want to look into baby net too. For
Yeah,
three
yeah, we're
population.
connected with baby.
Okay, fantastic. Any other questions? All right, well, we have materials on the table. You're welcome to take those with you. If you want more, we have more as well. But our contact information, myself and Meredith, we have lots, like I said, there's 9 of us, so I figured I'd just give you 2. And then our web address, to find our specific program, you'll go to DHEC. Tab at the top is health, and then under that tab, you'll go down to childhood and adolescence, and that's where you'll find our program. So.
And thank you so much once again, because like I said, we're really trying to get the word out. And if you, in your travels or whatever organizations you're within, if you ever feel that our presentation could be a benefit to your organization or your population that you serve or whatever, please also contact us for that too. Because like I said, the more people we speak to, the more people we can help. So, thank you.
Thank you.